All right, good afternoon. We've got the last panel here. We promised to be short and sweet so that we can enjoy the beverages and the food over here. In a bit of a change to the agenda, we no longer have Adam Bowler. We unfortunately had a bit of an accident. He's okay, but unable to be here today. So we're going to, I'll have my fellow panelists here introduce yourselves, but literally just want to provide the state of policy around primary care, value-based care, and also industry. So why don't we go ahead and do some brief introductions, and then we'll dive right in.
Yeah, so I was going to introduce myself as Adam Bowler, and anything I said would be reported under that byline, and it was amazing what I was going to get away with. My name's Clive Fields. I'm a family doc. I trained in Houston, practiced in Houston for over 30 years, and founded an organization called Village MD about 11 years ago. Village MD is a primary care-centered multi-specialty delivery system organization. We operate actually a little bit more than 700 clinics, taking care of roughly 7 million unique patients across, I think 11 states, 13 states. It's hard to keep track, but thanks for the opportunity to come and sit in for Adam today.
Yeah, and I introduced myself earlier, but I mean, just a couple highlights about community health centers. There's over 15,000 locations across the nation that serve 31.5 million Americans, and they're all in underserved communities. In rural America, 41% of the patients we serve are rural, 63% are minorities, and we have a workforce that represents the people we serve. We also have patient-governed boards, which I think is one of the best, if not the most innovative parts of our health system. The fact that you go to a community health center and it's led by the people in that waiting room, I think is an essential piece that other parts of the health system haven't emulated. But just a primary care doc and had opportunities to work in the private, nonprofit, and the public sector.
Terrific. And then I'll do a brief intro of myself. Ipsita Smolinski from Capitol Street. We do healthcare policy, regulatory analysis. We're based in downtown DC. We're not lobbyists. So value-based care is a decent portion of our portfolio, and love talking about it. I will say, kind of at the outset, there's not a whole lot. Well, yesterday we had CMMI, of course, unveil a new payment demonstration. Take a look at that if you haven't already for lower small revenue ACOs. Certainly the government is very excited about value-based care with the 2030 goal. Legislatively, not much is happening, especially now that we are beyond some of these payment deadlines. Well, we've got one more, I should say, around the budget, federal budget, of course, and with an election coming up in November, it probably won't be too active of a legislating year in healthcare. But I guess on that topic of CMMI, we talked a little bit in the previous panel, of course, about MSSP, APMs. I'll open it up to both of you to kind of talk about what you think has really worked, where we could see some improvements, I guess with an emphasis on the, what could we do better?
Yeah, so I'll take that one. I'm going to kind of second some of the comments in the previous panel that many of the APMs that we've been playing in have really been set up for primary care doctors to fail and other members of the community to succeed. And I think now about something that at Village we've just recently run into, and that is, many of you may be aware of this $3 billion urinary catheter Medicare fraud that has been uncovered. Once uncovered, we found out that we were on the hook for about 20 million of those $3 billion. And our question to CMS and CMMI is, what could we do about it? And the answer is, well, even though we were at risk and paid those dollars, we didn't have the either prosecutorial authority or whatever you would say to actually go out and charge and collect those dollars back in the instance of fraud. So things like that, where many of these APMs are set up in a way that even though we are taking full responsibility for the total cost of care, we have very little impact, even in the areas of fraud and abuse, in that area of in that total cost of care. So just and something that's come up, I'd mentioned to Ipsy just when we started, I think we're on the verge of seeing a skin replacement product fraud that will also exceed billions and billions of dollars that many of us in the primary care arena are actually paying for through wound care centers and other places that are taking advantage of fee-for-service billings or fee-for-service opportunities in ways that it's really hard to stay on top of. So when people ask me, where are we in value-based care? Where are we going? How's it going? The answer is not going that great. Like it could be going a whole lot better. I think about value-based care as outcome-based reimbursement, which sounds really easy, because if you do a good job for patients and you get good outcomes, then part of your reimbursement should be tied to that instead of just to the volume of services that you provide. And as simple as that sounds, it's very hard to get either the data or the contracts in place that allow that to actually work the way that it should.
Are you like the skunk at the garden party over here?
No, not really. It's like, I was well, maybe a little bit. I mean, you're sitting closest to me, so you have to tell me that. But no, hoping for better days ahead, absolutely.
Yeah, so I had a unique perspective as the chief medical officer at Aetna and looking at value-based contracts that we had with commercial Medicare and Medicaid plans as the third largest payer. And so in many ways, as a payer, you get to see the implementation of value-based care with the combination of employer-sponsored insurance, state Medicaid plans, and Medicare Advantage. And I will say I'm a bit more optimistic as it relates to value-based care. And it does come down to what the measures are, the outcomes over the costs, and ultimately being paid and having measures that it reduce costs, of course, because that is one of the quality aims, efficiency, but also improving these other outcomes. There are a couple things I was disappointed in that viewpoint, that I felt that certain measures should be included, and I'll emphasize this because I think primary care is meant to address health equity. Often equity wasn't valued in value-based care. So while you might have the most common measure that I saw used in value-based care was reducing hospital readmission rates. But as you know, there are disparities related to certain factors like race, ethnicity, socioeconomic status, where you see the readmission rates of certain groups are much higher than those of other groups. So in my opinion, value-based care should integrate the reduction of those disparities as well. I also believe that the diversity of your workforce should represent the people you serve. So whether it's gender, race, ethnicity, linguistic competence, I think often that isn't as valued if we value a system where we know the racial and ethnic, linguistic concordance of providers to those whom they serve as minority health becomes majority health is an essential component of what value-based care should become. So a couple things I want to highlight. I believe strongly that we need value-based care to be values-based in areas like diversity, equity, and prevention, with the focus on what I learned as a primary care clinician and what I delivered. Primary prevention, vaccination rates should be valued high. Secondary prevention, screening for cancer screenings and other screenings, often primary care clinicians, except for vaccinations, we're often early detection people. As a pediatrician, I would detect developmental delay early, or I'd detect, hypertension early before it becomes a stroke or a heart attack, or, diabetes before it becomes kidney failure, or, diabetic retinopathy, blindness. So in many ways, you're doing that, what I would call secondary prevention, and that's where the well-adult, well-child, well-adolescent visits are so essential in secondary prevention. And then, of course, you've got all these people with chronic conditions, and I saw the costs as the third largest payer. So much of the cost is spent in those chronic conditions and managing them. And preventing those hospitalizations, preventing those ER visits, preventing those specialty visits, I would even use the term, there's sometimes unnecessary specialty visits and procedures. Those are incredibly expensive. And we know primary care would prevent those costs. So ultimately, you need to then have tertiary prevention of those chronic conditions that contribute so much. So my question often was, as I looked at value-based care metrics behind the firewall of what a payer looked at, is are we valuing the things we really want to value, like prevention, like preventing those hospitalizations and ER visits, managing, diabetes and hypertension and depression as an outpatient and preventing it becoming an inpatient admission, where it's much harder to manage and the costs go up significantly. So to me, there's an opportunity for value-based care to be more values-based, but we still have a while to go there.
Yeah, Kyu, so I'm going to go back to something that was said in the prior panel too, that when we manage diabetes well in primary care from the onset of diabetes, it may be a decade before, or longer before those complications that we've actually eliminated start to show up as eliminated. And until, as a primary care doctor, somebody had mentioned it earlier, it's cradle to grave, it's womb to tomb. That if our payer system is based on a much shorter relationship than the value that we create, it's really hard to kind of get that alignment. Because in primary care, what is the most important thing we do? We build a relationship with a person. We don't remove a gallbladder or prescribe a drug. We build a relationship that can drive to a different level of wellness and prevention and health. But it's very difficult to be paid for that when payment is measured in a much shorter time period. Really easy to measure sternal wound infection rates. Like if they don't happen in the first 30 days, they don't happen. So it's super easy to kind of come up with measures to monetize the value of specialty performance. Much, much more difficult to do that on a primary care side.
I mean, and I want to highlight this because this is another thing I provocatively ask. Why can't we value the retention of your workforce? It's the quintuple aim, which includes provider experience. I'm glad provider experience got added. Now we know, especially post-pandemic, whether you call it burnout, compassion fatigue, vicarious traumatization, in many ways there's moral injury when you're a primary care clinician because you're experiencing the challenges of delivering care, whole person care, to populations with that 15-minute visit where half of the visit is you're a data entry clerk. So, but why can't we value providers that retain their workforce? I mean, to me, that's a reportable measure. You have it in your HR data. To me, the basics of primary care are continuity. And so to me, one of the worries I have about the future of primary care, my mentor who got me into FQHCs is Dr. Janelle Getchis, the Mother Teresa of DC. She's served in that setting for 50 plus years. That's what we want. We want people who've been in the community for 50 plus years. We should value that and expect that as a value in value-based care.
You were talking about social determinants, of course, and equity. When CMMI rebranded their ACO REACH program, do you think that what they did was adequate? And then I want to ask you also about ACO REACH and pivot to you, Clive. I know RTAs at one time were an issue. Maybe you could describe a little bit what that is and if that is something that we think is, coming up 2024.
I'll highlight, when I started practicing at Unity Healthcare in DC as a National Health Service Corps physician, I was unprepared. I had done this great training at Cedars-Sinai Med-Peds, but I was unprepared for the fact that health was so much more than healthcare, social drivers of health. The fact that I had a team of 9 other people, including a community health worker, a nutritionist, a social worker, a psychologist, a dentist, a pharmacist, a nurse practitioner, that team helped train me to understand that we had to go beyond the exam room. And in many ways, that's what health centers do. 70% of the people they serve are below 100% of the poverty level. So of course, you've got to think about broader determinants of health beyond the exam room. So I'm grateful. We had Chiquita at our conference just recently, our Policies and Issues conference, and I do think what was announced yesterday is a good move in the right direction, and I also think the work in social drivers of health is also good work as well, and we're excited to continue pushing, and this is what's important, whether it's the private sector, the public sector, the nonprofit sector, we all have to work together to make sure it's not just about healthcare, what's in the exam room, but what's beyond the exam room, and there's no better partner to advance social drivers of health than primary care.
Yeah, so I'm going to agree with you that healthcare is far broader than what happens in the exam room. But if we think about what we can control, many times it is what happens in the exam room. So going back to kind of the first panel today, talking about the primary care workforce, I keep thinking, why is that so hard to solve? And I can't get a straight answer for it. I know I've had this conversation with Tom and other people. Why can't we just stop training pediatric neurosurgeons at the Texas Medical Center this July 1st and eliminate some of those spaces and turn them into community-based primary care training sites? why can't we, through a tax credit, just pay people for doing activities that we would like? For every 5 years that you practice primary care, there is a tax credit available to you. It could be for teachers or firemen or police officers or whatever type of work that we wanted to incentivize, but it probably wouldn't be for pediatric neurosurgeons. So there's so many simple ways financially to solve the primary care workforce, and people keep telling me, oh, we can't do that because it would piss off Methodist or Baylor or Herman or Baptist or wherever the system is in the city that you live. But I think at some point we're going to have to just say, you know what, we're willing as primary care doctors to stand up and demand a different level of compensation and a different level of incentive. And it can be done in so many simple ways that I continue to struggle for why workforce is still an issue.
I mean, look, my first job right out of residency 22 years ago was I paid $80,000 a year to be a primary care clinician at Unity. Now, my National Health Service Corps scholarship that paid for my tuition helped, address, some of the debt that I would have been in otherwise. I mean, at its core, why? It's because we value specialists over primary care in terms of what we pay. That's what the system delivers. So ultimately, we have to challenge, as you said, the system. Why are my colleagues who I went to med school with, most of them became specialists? Because they were trained in a setting that was exciting for specialists. And if you don't find those mentors early in your career, you will often get attracted to be a urologist or a pediatric neurosurgeon. So why is that money there? Because the $24 billion that goes to GME through Medicare, that's part of funding, has not necessarily looked at valuing primary care. And in my opinion, you should incentivize those programs that contribute to the primary care workforce and or partner with local community-based organizations like FQHCs. Those should be the ones that get more of the funding to incentivize more primary care. But we have a system of choice. We don't have quotas, but to me, you just have to go further upstream to know why we are where we are.
So I think we are where we are because hospitals train doctors to fill hospitals. And I think there's a perverse incentive there. And if you go back to what GME funding was initially intended to do, which was to train physicians to meet the needs of the communities in which they are trained, then we actually should stop training doctors that communities don't need and start training doctors that they do need. And when you get back to social determinants of health, what can we control? We can control what happens in the exam room. And as we get better at that, we can control and extend our influence into the community. But until we actually own what happens in our 10 by 10 spaces, it's very hard to own the 10 by 10 square miles around us.
I just want to highlight I want to make sure part of the challenge of healthcare is to not vilify different groups and make it us versus them. So, I'm a big believer that we all have something to contribute to the system, and we all have to determine what we value. And so, hospitals have an important role in training, the future workforce. They've had an important role, but the numbers of 15% is not sufficient, and it's not what we need for our country as we continue to age and diversify. So I think having a conversation with hospitals, to me, it's like Hamilton, you want to be in the room where it happens. So we need to have it in the room and discuss it with hospitals and say, is this what we want? And how do we get to where we want, which is we want people to be healthier. And I will highlight that my experience with community health centers is that actually so much of the social drivers, housing, education, access to healthy choices, food as medicine, food pharmacies, civic health, voter registration, labor, transportation access, translation services, those are all delivered in the exam room, actually. So we have a model, community health centers do that today, and it's a model that's grown. When I started, we were only serving maybe 10 million Americans. Now it's 30 million, 32 million, 33 million. I believe that health centers are the best solution to serve 1 in 3 Americans to address primary care and health equity for all in those communities where, frankly, I'm not optimistic that a lot of the other sectors are going to fill that. In rural America and frontier America, in urban settings with severe poor, it's just hard to have a business plan focused on people who don't have insurance and can't pay for it.
We wanted to hit on private equity in healthcare. That is one area, particularly members of Congress get their knickers in a twist. Who are these PE funds? Why do they own hospitals, physician groups, et cetera? We have the FTC challenging Welsh Carson acquisition of, I guess it's anesthesiology groups. What is your view broadly on that, Clive? And we want to have a couple of minutes for questions. I know we're kind of running a little bit over here. But go ahead on the PE front.
Yeah, I think there are good and bad actors in almost every area in healthcare. There are likely bad actors even in the community health space. There are good actors in the community health space. But when I looked up the definition of private equity, it's access to equity outside of the public markets. That's the definition. So I started thinking about that. Well, I was fortunate that my father paid for a large part of my medical education. I'm guessing I accessed private equity. And when I started in practice, my partners actually loaned me the money to buy into the practice. So I'm guessing that I accessed private equity there. And I don't think anybody would say that those two examples are bad. Does the aggregation or accumulation of healthcare assets to produce a negative outcome, is that bad? Absolutely. But I'm not sure it matters whether you get that money from Bank of America or Annie Lamont, who was the private equity investor that first engaged at Village. So I would suggest that, yes, there are good and bad actors across all financing sources, but it's not the financing source itself that's the problem. It's the way the actors either use or abuse it.
Look, there's no question in healthcare, it's about mission and margin. You need margins to deliver mission, and you need a mission, to articulate why you need the margins. My perspective on private equity is just the importance of transparency. I think the reality is that as Clive referenced, there's a lot of parts of our system that are private equity funded that are delivering great outcomes and great results. The key for me is to create transparency for that awareness. I have witnessed, whether it's in different sectors, typically the public sector and the federal government, your ability, you're working with other people's funding, so there's not as much of an incentive to find out. I mean, you have legislation that leads to the funding that you deliver, but you're running on it, that's part of what's contributing to our national debt. But in the private and the nonprofit sector, you need margins to deliver on your mission. My key thing is to make sure there's transparency to where that money is coming from, so that when decisions are being made, there's awareness. I have seen there can be an incentive where you put profits over people. I don't think, and that can happen in any sector, is my point. But to me, to have the transparency on that is essential, because I think a lot of what is required in changing healthcare will take time. And if the pressure to put profits over that time, that can be very challenging. And I do think there are many parts of the healthcare system that are suffering because they don't have the time to make those changes, to build that trust in these communities, and to have that continuity to show that success. And so in my opinion, when you make investments, it's more ideal to have 10 years than it is to have 3 years to deliver on a lot of the changes that we need.
All right. Any questions from the audience?
Clive, you spend a lot of time meeting with business executives in boardrooms and health insurance CEOs and even politicians. Kind of going back to the title of this meeting, Imagining a Nation Without Primary Care, do they have a view of what that means to their business model if this doesn't work?
Yeah, so I'll share a meeting I was in with Jay a day or two ago from a likely member of the next Senate, who was thrilled to actually hear somebody talk about healthcare, because his party has completely ignored healthcare as a topic. So when 50% of the country doesn't think healthcare is a topic, and the other 50% only thinks it's a topic when they can beat the first 50% across the head with it, I think we have a problem. I think healthcare should actually be the topic of conversation when we talk about finances of American families, leading causes of personal bankruptcy. And I don't think we can solve any of those problems without an investment in primary care. If you asked the 100 members of the United States Senate what percentage of the healthcare dollar goes to primary care, I don't even know if you could get an answer, because it would be like asking something in Latin. It would be unheard of. And that even goes not always, but it even goes to the physician members of the Senate and the Congress. So what is the answer when I talk to those people? The answer is the same question that I asked in 1991 or the same thing I was told in 1991 when I went into practice, and that is that these healthcare costs are unsustainable. Guess what? I was in practice 30 years, and every year the healthcare costs were unsustainable. This year they're unsustainable, but I'm betting the system's not going to fall apart in 24, and in 25 they'll still be unsustainable until patients and employers and people that pay for healthcare actually decide that they're going to invest in the things that deliver the results they're asking for. Then we're not going to get the future of primary care that we're looking for, because I think everyone in this room agrees that primary care is the solution and the core to whether it's in a community health center, whether it's in a Privia model, whether it's in a village model, it's the support of physicians to deliver high quality primary care across larger population panels, not smaller population panels, through the use of team-based care that ultimately is that solution. And I think it's disappointing to hear so many politicians and business leaders and CEOs have so little insight and knowledge as to what that solution is.
I think we need to do a better job of marketing what primary care is. I almost feel like there needs to be a Super Bowl commercial, 30 seconds, that simplifies and tells what primary care is. Because I would suggest that, yes, in many settings that I've been in, whether it's in the C-suite, in the private sector, or members of Congress, there's a lack of understanding there. And I actually carry around a nickel. I just say, I show a dollar. How much of healthcare is spent on primary care, do you think? And they're like 25 cents, 50 cents. I'm like, no, here it is, a nickel. Is that what we want? No. Most people are like, no, that can't be right. Are you serious? And I reference the reports, but we haven't, in my opinion, we haven't done a good enough job of telling our story with those statistics to change, look at clean water or clean air or, it's that essential what primary care is, and we're losing. So I'm hopeful in some areas like community health centers. I want the private sector to have solutions as well. I want other sectors to have solutions. But I'm concerned that the literacy of primary care, the valuing of it, is not sufficient for us to get where we need to be.
Kyu, Clive, thank you so much.